again and welcome us to this edition of the Media Chat. We'll be talking about specific diseases and what NIMR has been doing in that respect. The contributions made over the years. He's going to tell us what contributions he has made himself, papers published, and how this has impacted on the health of Nigerians.
Good morning once again, the Director General, the Special Assistant on Scientific Matters, Professor Ezechi, colleagues, members of the press. You're welcome. As previously mentioned by the media consultant and Dr. Babatunde Adewale, I'm a public health parasitologist. I'm a director of research in the Nigerian Institute of Medical Research. I'm also the chairman of the Institutional Review Board on Ethics and member of the Lagos State Health Research Ethics Committee. I am also, on a number of occasions, worked as temporary advisor for the African program for onchocerciasis control in Nigeria. Over the years, I've worked on neglected tropical diseases with major focus on onchocerciasis, which is river blindness, and soil transmitted helminths. Neglected tropical diseases, they are a group of conditions which are caused by various pathogens, variety of pathogens, bacteria, fungi, parasites, and even virus. They are associated with rural areas, and they are regarded as poverty-promoting, stigmatizing diseases. When I mention rural areas, you wonder, rural areas, we're in Lagos, so what is it? You agree with me that majority of our population in Nigeria are in the rural areas. And it is this rural area that actually feed the urban or the entire country. So anything that affects the rural areas definitely has implication on food insecurity. Like I said, NTDs are majorly in the rural areas, and therefore it affects mainly the rural populace, which indirectly affects food insecurity in Nigeria. Over the years, with the advent of ivermectin, which is the drug of choice for the control of onchocerciasis, I'm talking about as far back as in the 90s, when control of onchocerciasis began in Nigeria. And the strategy for the control then was mass administration of ivermectin. Over the years, some other knowledge emerged that, because when we're talking about control of a disease, especially in terms of river blindness, we're talking about bringing the disease to a point, controlling to a point that it will no longer be of public health significance, but not that the disease will not be present. But with the body of knowledge that emerged from other studies, from Mali, Senegal, and also Nigeria, it was discovered that ivermectin, instead of just controlling river blindness or onchocerciasis, as you may find it more convenient to relate, it could also enable the elimination of this disease. So, instead of looking at control of onchocerciasis or river blindness, we're not talking about elimination, of onchocerciasis. So by 2009, there was a paradigm shift from the initial control strategy to elimination. That is, we're no longer looking at control, we're now looking at elimination. And over the years, we have also contributed to the body of knowledge to enable this. One of the things that we've been able to do over the years is that we have been able to identify the forest strain of Onchocerca volvulus using polymerase chain reaction. We have also been able to determine the seasonality of transmission of infection. One good thing about that, when we're talking about determining the seasonality of transmission, is that you can target at a particular time to treat, because ivermectin is an annual dosing. That is you treat once in a year. Though with the beginning of the elimination program, in some instances, we now do twice treatment in a year. So when you target the particular time, that means you are targeting the time that there will be high transmission rates. So when you target the time when there is high transmission rate, ivermectin, being a microfilaricidal drug, will be able to clear the microfilaria in the system of the person using the drug. And if you're able to clear the microfilaria in the system of the person using the drug, that will mean that the vector of that disease will have little or nothing to pick when it comes to feed. The vector of the disease is black fly or Simulon damnosum complex. Simulon damnosum complex feeds on blood. So when it comes to feed, it picks the microfilaria with, it takes blood with the microfilaria in the system. So when it takes blood with the microfilaria in the system, by the time it goes to feed elsewhere, by that time probably the microfilaria would have matured to the infective stage, which means that microfilaria that it has picked up would have migrated to the head region of the insect, that is the black fly. So by the time it's feeding again, it drops the infective larva of the microfilaria into the system of another person. So that's how the disease spreads. But if you target the peak transmission period, then the black fly will have little or nothing to pick. So that we have been able to do, and currently we are collaborating with the Federal Ministry of Health. Our lab here, the OncoSTH lab in Nigerian Institute of Medical Research, belong to a network of three other laboratories in the country that are supporting the Federal Ministry of Health in assessing the progress made towards the elimination of onchocerciasis. Basically what we do for Federal Ministry of Health, like I said, the treatment of onchocerciasis started in the 90s. So there you will hardly get any community, any endemic community in Nigeria that has had less than 10 years of treatment with ivermectin. So what we do here basically is that it is believed that in endemic communities where the treatment has gone on for not less than 10 years, we're going to children that are giving birth after this treatment has started are unlikely to get infection. So the strategy now is that for communities where treatment has been going on for the past more than 15 years now, children 5 to less than 10 years are actually the targets now, because it is believed that if actually the drug has been effective, children 5 to less than 9 years will not be carrying the infection. So what is happening now is that they carry out epidemiological survey in these areas, and they collect samples from children 5 to 9 years. And the samples are collected on dry blood spots. It is the dry blood spots that they collect from these children 5 to less than 9 years that they bring to us, which we support with our skills in the laboratory to analyze using the OV16 serology. So what happens now is that when they go to collect, for every community they go to collect the sample, you collect minimum of 3,000 samples. This is the WHO guideline to be able to achieve elimination. So you collect minimum of 3,000 samples, that is 3,000 dry blood spots. When you collect minimum of 3,000 dry blood spots, you bring it to the laboratory, to our laboratory. We analyze using this technique of OV16 serology. What we're doing is serology. We're looking at antigen-antibody reaction. So we analyze using our skills. When we analyze what we expect, it could either be positive or negative, actually. Depends on a number of other factors. When we analyze, it is expected for an area where transmission has been interrupted, it is expected that the rate of positivity of the DBS must be less than 0.1% of the samples brought to us. When it is more than that, that means transmission is yet to be interrupted in that particular community or in the areas we're talking about. Though for this, where we come in basically is in the epidemiological survey. That is where we come in. There are other people who are involved in entomological survey. They look at the vector, which is the black fly. And what they do with the vector is that they check for the infectivity of the vector. That is the presence of the parasite in the vector using the O150 PCR technique. So the beauty of this is that we're using serology, they're using molecular biology technique to be able to pick the minutest infection, so that when we say it is infection is interrupted or transmission is interrupted, yes, we are sure transmission is interrupted in this area. This has been going on for a while, and we have successfully analyzed quite a number of samples. And in Nigeria today, at least we could talk about 10 states that are currently, or that could currently say that transmission has been interrupted. That is, there is interruption of transmission in about 10 states. For Nigeria to be declared free of onchocerciasis, or that we have eliminated onchocerciasis, there are guidelines. And even in these other areas where we're talking about interruption of transmission, there is what we call post-treatment surveillance. That is, even when we say, okay, in the samples we have analyzed, we recorded less than 0.1% positivity. There should be post-transmission surveillance for about 3 to 5 years, in which case they keep track of what is happening in the area to be sure that there are no recrudescence in the area. And it's after the post-treatment surveillance that we now go into post-elimination surveillance, It's after that that the country can actually be declared to be onchocerciasis free, or that we have eliminated onchocerciasis in the country. That is how far we have gone with onchocerciasis. We've also done some other, like I mentioned earlier when I was talking, that we work also on soil transmitted helminths. What we have been able to do with soil transmitted helminths is that we have also looked at trefoil factors family protein in children, school-age children. What's trefoil factor family protein? What it does is that it helps during infection. It helps with repair of tissue. And during our work, we've realized that trefoil family proteins, the infection of helminthic parasites modulates the trefoil family proteins, which in some instances are species specific and age specific. Since we have realized that in a study that we carried out a few years back, we are now working on that again to see that what will happen if there is co-infection of soil transmitted helminths with Helicobacter pylori. We're talking about Helicobacter pylori because the risk factor for the transmission of Helicobacter pylori and the soil transmitted helminths are very similar. Mode of transmission is fecal-oral mode for both, or for Helicobacter pylori it could be oral-oral. And the two infections, they thrive well in poor environmental and hygienic conditions. So we're now looking at what role will trefoil factor play if the two infections are together. Will it help in reducing the severity of the Helicobacter pylori in infected people? Because like I said, Helicobacter pylori is the organism incriminated for ulcer. And during ulcer, there is mucosa damage. The trefoil family proteins, the trefoil factors family proteins are usually found within the intestine and the stomach. So we're looking at, will there be an increase in the amount of trefoil factor family protein when we have co-infection with helminth or not? So this is something that we're about to start working on, and hopefully, probably in another 12 months, we have cause to call you again to let you know our findings concerning this. Thank you very much.
Yeah, I am Dr. Kazeem Adewale Solale, a statistician turned into biostatistician in NIMR. As a biostatistician in NIMR, support almost all the researches that are being conducted in NIMR, including what my Ogas just talked about, and also my other colleague at his right-hand side. So, but what I've done recently is what I'm going to speak to, which is basically on empowerment models for improving HIV patient adherence to antiretroviral drugs. The advent of ART has led to advancement in the treatment of HIV/AIDS as a chronic and controllable condition or infection. The literature has established the fact that HIV-infected patients who benefit from appropriate and timely treatment are estimated to have similar survival rate to HIV-uninfected patients. However, adherence remains a major problem in the low-resource setting like Nigeria, as many of the patients they face challenges with adherence. It's not that they are not willing to adhere, but for the lack of income. Some of them do not have financial muscle for them to take care of what is involved in terms of transportation, in terms of registration at the clinic. And that is why we ask, what can we do to help them? What if we empower some of them? Can that help their health? Will they be able to adhere? Will they be able to go to the clinic regularly, pick up their drugs? And that's what brings about that study. Because it is not just even the drug, but the skill. They need skill, they need empowerment, so that they'll be able to take care of their needs. They'll be able to gain independence. They have that confidence. They have money which will spur them to, go into the clinic and pick up their drugs for use. So what we did was we tried to conduct a pilot randomized control trial, whereby we have about 50 of the patients randomized into two groups, 25 as the experimental group, where we train them and also give them a startup empowerment material. The other group is the control. And at the end of the day, we realized that the adherence rate at the baseline for the experimental group, which was 69%, rose to over 100%. And even that of the control group from 84 to 99%. However, there is a statistically significant improvement in the empowered groups based on the statistical test that we conducted, which gave us p-value of less than 0.01. So based on this, we recommend that the funders and policymakers should integrate empowerment into HIV care programs, because it is time to invest in our HIV patients and not just drugs. They need this empowerment to give them purpose, it will give them income, it will give them independence. When they are able to afford, when they have income, they have that confidence, they go to the clinic and pick up their drug regularly, and this will improve their quality of health. It is time for us, like I said earlier, to invest on them rather than just giving only drugs. Thank you.
Yeah, good morning, everybody. Yeah, I'm Adewale. I'm a medical sociologist working here in the Nigerian Institute of Medical Research, specifically in the public health and epidemiology department. As a medical sociologist, I play more or less what we call a complementary role to the natural scientists that we have in the institute. Just as my senior colleague, Dr. Adewale and Dr. Oshoreli have made their presentation. My own role is more or less like adding value to the natural science research that we do here in the institute, because there is no point having high-falutin technological innovations, developing interventions to help solve health problems in the country, like in the area of onchocerciasis, HIV/AIDS, cholera, and all these come into nullity. And why I say this is because if you develop all these innovations and interventions and not get them across to the communities, and you find people not accepting to use all these innovations, that's waste of energy, waste of resources, and waste of time. So what I do as a medical sociologist in the institute is I go down to always look at the sociocultural factors behavioral factors of people in the community, see how their social life, the people they relate with, the family, the community, the environment where they live, the house type that they live in, the food they eat, the work they do, how all this in encompassing affect their health. Just as Dr. Adewale mentioned the issue of onchocerciasis, we've carried out research on onchocerciasis to test the knowledge and perception of people about this onchocerciasis. You won't believe that people have a different view from the scientific explanation for cause of onchocerciasis. Well, as we all know, the black fly is the main cause of this onchocerciasis. But the people in the community, just as already said, majority of Nigerians live in the rural areas. In these rural areas where you have these diseases most predominant, they don't see most of this black fly as a threat because they attribute the cause of these diseases to other issues, maybe witchcraft, an act of God. This is as an act of God. Recently, we conducted a survey on malaria, and you won't believe in this 21st century, 2025, people still believe walking in the sun causes malaria, and drinking maybe bad food, eating maybe contaminated food causes malaria. Someone even said poverty is the cause of malaria. So these are things we still need to address, the health literacy of people in the country. So this is very, very key, because when this is still at its lowest ebb, then whatever technological innovation that we may come up with, that the country will spend billions of dollars in bringing into the country to help solve these health problems, we will still not be able to overcome most of these health problems. That's why it's very important that most of the findings that we usually come across, we usually advocate for health literacy. So it's very important that we emphasize the importance of health literacy, public health education for our people, so that they will know the actual cause of most of the diseases that we are talking about, how to prevent them. And one of my main research interests now is on climate change. There is a study I just completed on climate change in Lagos State, and I haven't collected meteorological data since 1988 to 2022 for Lagos State, and malaria preliminary data from 2007 to 2002. The data show that climate change has actually come to stay in this environment in Lagos, because there has been changes in the data that we collected from the Nigerian Meteorological Agency in Abuja. It showed increase in temperature for Lagos, and this, according to the WHO, climate change is one of the factors that's been considered as a big challenge to eliminating malaria globally. And as we all know, Nigeria is the country with the highest burden of malaria worldwide, contributing over a quarter of malaria cases being reported globally every year. So, regarding this, concerning the climate change work that I just completed now, asking people, although they were aware of climate change, they've been hearing about it on radio, TV, jingles on radio, watching it on TV, reading it in newspapers, but the knowledge of what climate change is and what they could do to contribute to reducing greenhouse gases emission is not there. It's very, very low. I imagine 1% of the people sampled actually could tell what climate change, what contributes to climate change and how it affects them. Only 1% of them could tell what climate change is all about. But almost about 70-75% have heard about it, but majority didn't know what it actually means. And this also affected the use of one of the interventions in preventing malaria, which is the long-lasting insecticidal net, the mosquito net that we all know. When people were asked why they have the net, but they don't use it, why? Heat. They complain of heat. The weather is hot, but so they have to make a choice. It's either they allow mosquitoes to bite them, or they sleep without the net and allow mosquitoes to bite them, or they sleep under the net and bear the consequence of the heat. And one of the contributing factors to non-use of the net is the housing design. You know, the housing design is still very, I would describe it as still poor to some extent, or to a large extent if one can argue it out. Because majority of those we interviewed, they live in one-room apartment. And in this same room apartment, you have all the furniture, you have the bedding. So it's very inconvenient for them to find a place where they can conveniently hang this net to sleep under. So they rarely make use of the net because of the inconvenience in the room, and again because of the heat. You know, because it's in the room, you have the father and you have the mother, probably 3 or 4 more of the children living in the same room. So all of them, so how do all of them now sleep under the net in that single room? Because in there, that's what we find out. More of those who live in flats or a whole house use net more than those that live in the single room. So this suggests the need for a kind of redesigning our housing in Lagos to give room for proper use of this intervention in preventing malaria. And also, recently too, we just concluded a work on the knowledge and perception of mothers of children who are eligible to take the malaria vaccine in Ogun State and Ondo State. So we interviewed them, that's children 5 months to 36 months, to know their willingness to allow their children to take this malaria vaccine. You know that we have this pilot going on in 2 states in the country, Katsina, Kebbi State and Akwa Ibom. So this is the malaria vaccine is being transferred in these 2 states before it will probably then now be scaled up to other states. But before then, it's good to always have this basic information about level of acceptance by the time these vaccines is being rolled out to these other states, to know, just as we experienced that of polio and even recently COVID-19. So, you know, from our own assessment, the level of acceptance, you know, hypothetically now, was very high. But we don't know, maybe by the time it gets to the community and rumors start flying around again, so things might change. But from their perception, from what they've heard about the vaccine, and they know the implication of malaria to the health of their children. You know, many children usually die because it's one of the top killer of children and infants too in the country. So they know the consequence of malaria, both for the children and for adults alike. So the acceptance rate was high, but the people they advised that they want government to channel the distribution of these malaria vaccines mostly through the public health facilities, where they have more trust in accessing health care from the public health hospitals. And moreover, they advise that they will need more community engagement so that government, health workers, CSOs will come in to dispel whatever rumor and misconceptions people might want to start having about these malaria vaccines. Thank you.
I just want to touch on 1 or 2 things. we've had expressions like fecal-oral. What does it mean? Feces, mouth. You pass something out in feces, you don't wash your hands, you ingest the eggs or something through the mouth. Fecal-oral. Oral referring to mouth to mouth. I just felt I should explain some of these jargons. No, I'm not saying you're speaking jargon, sorry. I recall Dr. Oshorale mentioning p-value. What does p-value mean? It's a statistical expression when you are trying to test for significance of something you are putting forward. And use mathematical expressions to characterize what you have discovered. And there's a line that to draw. If the value is above a particular or below a particular level, then you can talk about whether it's significant or not. I hope I'm right, sir. But that said, I just want to comment a little bit about onchocerciasis. It's called river blindness because the vector responsible for the transmission, the black fly, the Salmonella genus, are found usually around rivers. And why river blindness? Of course, the skin manifestation occurs long before the manifestation in the eyes. But with regards to the eyes, you find that the microfilaria, which is the larval form of the adult worm, moves around in blood. And they get into the eyes, affect the outer part of the eye, which can result in cloudiness. And you can also find some bumps there. But beyond that, they can also affect the back of the eye, which we refer to as the posterior segment. And at the back of the eye, they invade an area referred to as the retina, which is involved in interpreting visual messages entering the eye. And could also affect the nerve, which is the optic nerve that carries message from the eye to the brain for interpretation. So the presence of the organisms in these areas with concomitant stimulation of inflammatory changes is what results in the blindness. Remember I mentioned the fact that the one in the skin is usually due to the presence of the adult worm within the skin. They form nodules and they're like rashes accompanied by intense itching. And different people will react to it differently. At times the rashes could be painful, and in making the diagnosis, biopsies of that area will be taken, put on a slide, and the microfilaria or dialog can be seen moving away from underneath. And this can be stained and examined in the lab. Of course, we've also been told that other techniques include using PCR,
yes,
genetic studies,
yes,
for the characterization.
My question is river blindness.
Okay.
Is it I want to finance the communities. You just say communities. And is it deliberate? You don't want to tell us the stage where you're carrying out this study? I want to finance it. We measure 10 states that have received the interruption or translation. I want to find out the state, and that is positive. Let's also highlight that in our report. That's one. So I want to find out when you start the collection of sample. Is it a recent study? When did you start collecting the sample? And then you talk about that several stages that the girl have to undergo before they get to, before they can be declared free of River Blindness. What stage are we right now? And from your whole projection, when can you get to that coordination stage?
Thank you very much. I'll start with the first question, that is mentioning communities. It should not be ethical for me to be mentioning specific communities that are positive, because it may result to stigmatization, so I won't mention, but we have a number of states like where they have achieved the interruption of transmission. We have Kaduna, Nasarawa, Plateau, Anambra, Ebonyi, Abia, and others.
So my next question was on the elimination stage.
Yes.
What stage are we right now?
Okay. Right now we're at the stage of interruption of transmission. Actually, because like I mentioned, treatment has been ongoing for more than 15 years. So in those places, we have what we call transmission assessment survey. So the first thing that will be done, and that is when they go in to collect samples, transmission assessment survey, is when they collect the samples, that is dry blood spots, from children 5 to 9 to less than 10 years. What they do is the transmission assessment survey. They bring us the DBS samples, that dry blood spot samples, the finger prick blood on something like filter paper. So is that filter paper, in layman's, like, let me call it filter paper, is what they bring to us in the laboratory, and we elute from those filter paper. We elute for serum. It's the serums that we make use of. So that is the transmission assessment survey. It's after that, when we have analyzed the samples, not less than 3,000 samples per state, when we have analyzed the samples and we have found that the rate of positivity of the samples is less than 0.1%, then it will be taken that transmission interruption has been achieved. That is phase 1. The phase 2 is the post-treatment surveillance. That is phase 2. So that post-treatment surveillance is after the first phase. Then they now do surveillance in that particular area to be sure that there is no recrudescence. Recrudescence is when you think an infection has stopped and suddenly you start seeing it back. To be sure that there is no recrudescence. Then if there is no recrudescence between 3 to 5 years, then it is taken that they passed phase 2. Then they move to phase 3. It's after phase 3 that WHO will now send, that is, if it has been achieved throughout the country, will now send independent evaluators to come and evaluate. The target for the country is 2030, and I believe Nigeria is on course.
I have some questions. My first question goes to Dr. Adewale. And my question is, what's the efficacy of documenting that has been administered to this people, and what are the side effects? How do you deal with the side effects? My second question goes to Dr. Sholade. In empowering the patient to be able to have income or whatever it is to come to the clinic to register and take their drugs? Are you involved in skill acquisitions for these patients, like maybe bean making, baking, and all this stuff, so that maybe they can do within the confinement of their homes and their communities to be able to generate funds? And my third question goes to Mr. Adewale. Now, do you involve the youth, because Nigeria is an heterogeneous country where there are so many dialects and languages. So in involving in community engagement and socio-cultural, engagement in medical research, how do you get to relate with people in the community of different cultures and dialects that are not English spoken or educated to be able to understand the languages that are being spoken in the urban part of the country? Are you going to get linguists to be able to communicate to them in their dialects, or how do you, deal with these people in those parts of the country? Thank you very much.
Thank you very much. Ivermectin, that is the drug of choice. It's a microfilaricidal. One of the studies that we carried out in the early years was impact of ivermectin treatment on transmission. Ivermectin, like I said, is microfilaricidal, and we have found it very efficacious. Actually, you talked about side reactions. I mentioned mass administration of medicine, that is mass administration of ivermectin in communities. For WHO to have allowed mass administration, that means it has little or no side effect. Actually, the mode of administration, they call it community-directed treatment with ivermectin. And why they call it community-directed treatment with ivermectin is because villagers are being trained on how to treat themselves. That is, communities decide, that is why they call it community-directed. Communities decide and choose somebody that they feel the program can train to treat them. So it's like community doing the treatment by themselves. The side reactions are very minimal, and that is why it is being allowed to be done en masse. And that is why community people are being used for the treatment. Nigeria is very vast. How many health workers do you want to train to start going around? It will be one, it will be very expensive, and two, I'm not sure that health workers can all the nooks and crannies. So we use, the mode of treatment is community-directed treatment. Then, like I said, ivermectin is very efficacious. In the study that we carried out years back on the transmission, impact of treatment on transmission, we've seen that when you treat with ivermectin, for the next 6 months after treatment, you may not be able to recover microfilaria. Thank you very much, sir, for talking about skin snipping. You may not be able to recover microfilaria from the skin of the infected person. That is for the first 6 months if you treat with ivermectin. So you can be rest assured that ivermectin is very efficacious. And like I said, when we started, we thought that it would just be able to control the disease to a level that it will no longer be of public health significance. But now, we're not talking about elimination, because studies have shown that ivermectin is efficacious enough to be able to eliminate onchocerciasis. That is, having treated for about 12 to 15 years. It takes a while, actually, because when you continue to treat, it has effect on the microfilaria. It kills the microfilaria almost immediately, but the adult ones that are still there within the system, they keep producing, and that is why you need to treat for that long, so that when you continue to treat, within the 12 to 15 years, the adult one will die, and there will be nothing to produce again. And the medicine will be able to kill all the microfilaria. So it's very efficacious.
Is it free?
It's free, yes. Yes. Thank you very much. Ivermectin is free. It's been donated, and it is free in all areas where it's being used. Free.
Yeah,
In all endemic communities.
Let me
Yes.
say something. You asked the question, free. Nothing in life is free. Even in a free town. Somebody, somewhere,
It's paying.
is paying
Yes,
for it.
yes.
You know, Nigeria always, when it comes to health, that's when we start talking about free, not free. All of us kill ram during the Ileya Salah. We all save money. Christmas is coming, we are beginning to save money again. We are going for Shebi, and now some Shebi are 500,000. We are saving money through that. But when it comes to health, everybody says, nobody has money. And I think we have to start rethinking when it comes to health. The only way you can get a good health, the countries that have good health are countries that taxpayers or health insurance, people pay money for them. Nigerians are running to UK and using a system that is built on people's taxpayers' money. And people are not paying. They quickly go there, have their baby or something, and run back to the country. And they are not paying. And they continue giving Nigeria bad names. It's people who pay taxes for those health services. People are leaving Nigeria together. And I appeal to the journalists that we need to emphasize that it's a responsibility of everyone, all of us, to take care of our health, just like we take care of other things. I agree there's a section of the population down that the government caters for. And that's what the health insurance is supposed to cater for. If people like me and you who pay our health insurance, pay our taxes, government will be able to cater for those lower group that require that. And when people now present on emergencies, accidents, it's actually that same money from those taxes and government that are pulled together to be able to take those few people. But if you don't do that, and you now arrive at a government facility or a private facility, and you expect magic or miracle, manna no longer falls from heaven now. It's in the time past. I said, well, let me just chip that. So you want to add something to that?
Oh, okay. I was smiling. I was going to look at the issue of free from a different perspective. I remember during the time of COVID, ivermectin was being said to be effective against COVID.
Yes.
And the price of ivermectin skyrocketed. A small bottle like that costing about 80 to 100 thousand. I bought it. Because I was ready to use anything.
Anything just to prevent this.
I'm a COVID survivor. But, so when you were talking about the thing being free, I was just smiling. That's all, sir.
Yeah.
Okay, any other?
No, I think she has me.
Okay, oh yes.
Okay, thank you for the skill acquisition program. I would say yes, because the empowerment model in the study, we define it as a two-phase intervention approach comprising structured lectures and practical vocational training. So under that vocational training, we have skill acquisition programs such as catering, bead making, hair making, and liquid soap making. Thank you.
Can I ask you a question?
Yeah.
I mean, with this US course formed cutting of the HIV,
Yeah.
how is Nigeria like trying to bridge that gap? I don't know if you have any information on that. And we were just tackling one issue. What if they say there's no more drug? Are we prepared for that?
Yeah, that's one of the advantages of this particular study. And what we are thinking now is how to scale up. And for us to scale up in the direction of empowerment model, we need more participants in the study. I went through the findings. We had about 24% event rate, meaning that if I need about 6 variables as predictors of adherence, considering empowerment, then I need 250 participants to be part of the study, which implies that we need more than what we have spent. We are close to 75 million to be able to do that, because if we don't act now and that happens, it will affect the number of our patients. Some will die, and we don't pray for that. And that's exactly what we are looking at as a team in NIMR, that if the funder will come and help us, it will be a multi-center study, as we are trying to propose. So that's the proactive action that we are taking in that direction.
Yeah, thank you. In response to your question on how do you communicate to people in their local languages as part of community engagement, given the multilingual nature of Nigeria. Yes, when we go into the community to do our research work, we engage local guys. I know, me like being a Yoruba man, that doesn't stop me from going to the north, going to the east, going to the south to do my research. What I usually do is I engage a local guide who will help in doing interpretation, translation of interpreting the languages between myself and whoever I'm interacting with. And at the end of the day, after the data that have been collected, analyzed, and results are now to be disseminated to the community, we don't go directly to the community. We interact with the state and the local government on what to do, and by so doing, what they need to do is just do the posters, jingles, whatever ways, that's information, education and communication, or behavioral change communication strategies they want to adopt in disseminating the information to the locals in their respective states and local government is use of the local languages, so that so that you can achieve effective communication of the findings and trying to pass the message across to the people at the grassroots on what to do and what not to do for change to happen in the community regarding whatever health problem that we went there to investigate.
Thank you.
Blindness rates of this river blindness, because the hearing of river blindness is when I was in primary school. Then again, the sleeping sickness, which is caused by sea fly. So what is the prevalence rate?
We still have over 43 million people that are still at risk, so that are currently eligible for treatment.
Are there parts of the country where this prevalence is more prevalent?
Like I said, because the treatment has been ongoing for quite a while, in some places it has subsided, and one thing now is that the insecurity in some states is preventing people going into, like such places. It may be difficult to actually get people treated, but yes, it's prevalent in almost all states of the country except Lagos State and River State.
Are you supposed to other
Oh yes, we can. We're doing fine.
compared to other African?
Yes, we're doing very fine.
Are you surprised? Are you surprised that there's good news in this one? We've had so much bad news.
We're doing fine.
I said
really.
we've had so much bad news in the country that
We're doing very
once
fine.
somebody presents something positive, you realize that people keep asking questions.
You say? Yes, only Niger in Africa. Only Niger in Africa. And you can't compare the size of Niger with the size of Nigeria. Probably the size of Niger, I'm not sure if it's up to Lagos State.
Okay, what I want to ask.
Niger.
Not land mass.
Population.
Population wise, not land mass.
I want you to clarify the drug for the river blindness. Is it a preventive measure for those children that you mentioned that get it? When they get it, now they are immune to getting infected?
The thing about it, like I said, it's mass administration. If you are in an endemic community, whether you have it or you don't have it, you get it. You get the treatment. So definitely, if you get the treatment, even when you don't have it, you won't have it.
Okay, so you talked about the treatment that for 8 to 10 years. Is it that these people are placed for this treatment on a yearly basis?
No. I didn't say the treatment is for 8 to 10. Are you talking about children, or let me get your question right?
No, you said it's efficacy enough to eliminate that when they take the drug that they have maintained, it's efficacy enough to eliminate it, having treated for 8 to 10 years.
No, I said in Nigeria we've treated for up to 15 years.
Oh, okay.
The treatment started as far back as 1992 or 1990, thereabouts, early 90s. The first treatment was in 1990 in Kaduna, and thereafter we continued treating. Then we were looking at controlling, that is, bringing it to a point that it will no longer be of public health importance. But now we're looking at elimination from 2009 upwards.
Sir, I want to mind the clarification. Research in Lagos and River States that because why?
Okay. Yes. For example, I'll talk a little bit about the transmission, and yes, the transmission. Onchocerca volvulus, which is the causative organism, is transmitted by the vector we refer to as black fly or Simulon damnosum complex. Simulon damnosum complex breeds around fast-flowing rivers with rocky substratum. So that is why you don't have it in Lagos and rivers. If you go to Ogun State, you have it, or some other states.
Talking about children, you said 5 to less than 10 years, and you said talking about children that your target is
Yes.
5 to less than 10 years, and
Yes.
you said 5 to less than 9 years. I don't know what it's
No, I mean 5 to less than 10 years or 5 to 9 years.
Okay.
So, sir, you mentioned that in 10 states in Nigeria now, there's transmission interrupted. So is that that word interruption, it's borders, is that going to come up again?
It could come up again.
And that's why, when he was talking about science is, when you are doing something based on science, it's not abacadabra. You have your steps. And that's why he outlined those steps before you get to elimination. The stage you are now is you need to interrupt transmission. When you interrupt transmission, what it means is that transmission between individuals are not going on. But some people may still have it. So the stage you need to is to clear what they have. If you stop, what it means that they can still transmit. So and that's why you measure each step. Remember, you mentioned post-surveillance surveys, and you continue until the country is declared elimination.
What exactly is NIMR's role in this elimination process that we're talking about?
Thank you, sir.
Then 2, please clarify the duration of treatment again.
Okay, sir.
For how long are we supposed to do so that
Okay.
people will be there?
Okay. NIMR's role currently is that we're supporting the Federal Ministry of Health We belong to a network of 4 laboratories in the country that are doing this for the Federal Ministry of Health. So we are supporting Federal Ministry of Health to assess the progress made towards elimination. And that's what I said, what we do basically for them, we support them with our laboratory skill. That is what we do. They get the samples, they bring it to us, we analyze, we give them results. The second one.
The duration.
Can we address, before you move to duration, I think we need to address the issue of NIMR's rule. I categorize it into 3 components. One is technical expertise. We have people like Adewale who are qualified experts in that field that provide that technical they need. 2 is laboratory backup. Like he said, some of the samples, only 3 laboratories in the country, and NIMR is one of them that produce samples and analyze. And the 3rd one is, which is our role as the agency of the government that conducts that, is the research backup. For you to confirm those eliminations, those interruptions, you need the research components to the program. Like mass administration is programmatic, but what actually will confirm whether you actually a result or not is the research, and that's where. So just to summarize for the other journalists, 1 is technical expertise, 2nd is laboratory support, and 3rd is the research backup for the national program.